Recording. So the first topic, we already covered the congenital heart disease and this global developmental delay. So I try to cover this global developmental delay, the whole developmental topic with the psychiatry. That's why I skipped this one. This is kind of very important. So we'll try to cover with the psychiatry because you need to know the autism, attention, ADHD, and everything is written very nicely over there. So once you have a concept of psychiatry, it will be easy for you to read this one, this developmental. So endocrinology, you can study this with the endocrine. So it's kind of similar. All you need to know is how you are going to treat in pediatrics, the endocrinology, and how you are going to treat that same endocrinology in adults. So if you are reading endocrinology, try to do it in both adults and in children. So it will be very easy for you. So we can, if we try to if we did the endocrinology topic, so we can cover this one along with it. So then is fluid. So let's start with this one. So, okay, fluid and electrolytes. So you need to know a little bit concept. It is not like a very important thing you need to know, but just for the concepts. Total body water is basically intracellular and extracellular. Most is basically present in the intracellular. So then comes the etiology. What happened when you are approaching a dehydrated patient? Child. So you need to know either there is a decrease in intake or there is an increased losses. So you need to know this kind of two things can present with the dehydration. Maybe the baby is not taking enough, and the other thing is already having enough loss, and the intake is not sufficient to meet the losses. So that's why this can present with the two, intake and then losses. So intake would be like poor intake, having maybe candidiasis, any breastfeeding problem, anything underlying going on. And then eating disorder, maybe the parents are not mixing the formula properly. So all of these factors. Then comes the increased losses, all diarrhea, vomiting, bleeding, everything can present with that. Fever, burn, hemorrhage, stomatitis, or osmotic diuresis, hyperglycemia, DKA, diuretic DI. So it can present with any of this. Then comes the management. So you need to know the first five criteria. What is the first one? Determine the degree of extracellular volume contraction. How much is the water lost? Is it mild? Is it moderate? Or is it severe? Then comes determine the likely electrolyte disturbances. So you already find out that the volume is lost. Now you need to know which electrolyte is lost, which electrolyte is mostly lost. So you get to know a bit about it. So this is the first thing, and then you have to find out this one. And then on the next one, what are you going to do is determine if the child requires per oral and IV. How you are going to check it? I will, there is a table, I'll show you. So then you have to see the degree of dehydration, no dehydration. So we will check this one. Then you need to know the return the child to a normal value and electrolyte status by replacing current deficit.
Okay, no problem.
So on the basis of that, you are going to determine what the patient is needed, and then you have to treat that dehydration on the basis of that. Then comes the fifth point is basically provide the appropriate fluid and the electrolyte maintains daily requirement. So you have to see. So you need to remember this formula. When I will read it, I will let you know. Then comes the 6th point, continue to the monitor fluid and electrolyte status. So now starting from the first one, I read it generally. So you have to know all these 6 criteria, and then you are going to check wherever it is applicable. So on the basis of that, you are going to
lecture to लेना वो आ रहा है ना online.
I just going to mute it just a second. Okay. So now coming to the first one. Now you need to know if it's mild, is it moderate, or is it severe? How you are going to see, this is all the presentation. The BP will be normal, or is it going to be low or decrease? Then the pulse, is it normal or is it rapid? The urine output, is it totally lost, like there is no urine coming out, or is it like markedly decreased, or is it decreased? So oral mucosa, they will present you these kind of features in your scenario. So on the basis of that, you will get to know this is mild, this is moderate, and this is severe. So eyes are normal, sunken, dehydration. So we already know how the general presentation of dehydration look like. So on the basis of that, you are going to differentiate it. It's either mild, is it moderate, or is it severe? Then comes the assessment of the severity of that dehydration. This is how you are going to do. So you are going to check all of these things, and then on the basis of that, how the presentation is, you are going to see if it's mild, moderate, and severe. Now coming, you already find out that the baby is, let's suppose, mildly dehydrated. Now we need to know if there is an electrolyte disturbed, right? Because this is very important. You can miss the fluid intake, but you cannot miss the electrolyte. You have to treat the electrolyte first, then moving on to anything else, because the electrolyte could be very, very dangerous and fatal for the patient. So that's why we have to move on to the next step, is basically electrolyte disturbance. So we are going to check it's determined on the dehydration and the type of the fluid loss. Maybe the fluid is losing too much. That's why the electrolyte is already disturbed because of the fluid. Instead, like how vomiting presents with hypokalemia, hypochloremic metabolic alkalosis. So you need to know how this particular presentation is presenting along with it. You know, you don't need to remember the various contents of the body fluid. This is kind of like too much and you cannot remember it. So just if you are still like, you know, feel like I need to read it, just give it a little read. You cannot remember it, I know. For moderate to severe, what are you going to do is basically initial investigation should be urine analysis and blood work. So you need to know which electrolyte is disturbed. Is it potassium? Is it sodium? Is it chloride? Is it glucose? So you have to know, and then you are going to treat from the electrolytes and then from there on. So you have to check if it's the renal functional is problem. Maybe the urine output is not coming properly. So that's why everything is stuck inside in the body, and that is causing too much electrolytes inside the body or too much fluid inside the body. So you have to see what is the problem going on. So according to that, you will treat the patient. So the second step would be electrolyte disturbance. Determine if the child needs per oral and IV dehydration. A very nice topic is written here. Sorry, table is written here. So degree of dehydration, you find that there is no dehydration. What are you going to do is you need to tell the patient that this is diet, take the diet, and if any vomiting or anything happen, just take a fluid, right? How you counsel somebody who came to you, oh, I just vomited. So you said, oh, take extra fluid, right? So that's how you're going to say replace ongoing fluid. Now comes the mild one. Mild one, you have to start with the rehydrate ORT, then replace the ongoing losses, and then age appropriate diet. So you cannot let the child who's coming along with a mild dehydration, you're not going to ask them to stop eating or stop taking the regular diet. You have to counsel that take the diet, rehydrate. Along with it, you have to replace the ongoing losses. So many people, when they are treating, what they do is they give rehydration, they do give diet, but they forget about the replace ongoing losses. So don't forget about ongoing losses, is very important. You have to treat along with it, because if you are giving just this much and this much, this is not, you are not giving replace ongoing losses. So this is not sufficient or not enough for the child. So then coming to moderate, you are going to do the same, but the fluid level is little different. 100 milliliter, and this is basically 50 ml. Then or along with it, replace ongoing losses and then age appropriate diet. Then the swear, you cannot take oral, because swear you have to start with IV with the normal saline 20 ml, and then reassess. If necessary, repeat it. If not necessary, then start at least the ongoing losses and ORT. As soon as the baby start coming back from the swear to moderate, you are going to switch it from IV to oral as he can take it then. Otherwise, you have to continue with IV. If he cannot continue with IV, then you have to move on to, sorry, if he can continue with the oral, then you have to switch IV as soon as possible to the oral. So you need to know this. Then special consideration is basically SIADH. So you have to see if it's hyponatremia. So it is very important when you are giving fluid. If you give too much fluid, what happens is hyponatremia could happen. So you have to see which fluid you are giving. You shouldn't be giving hypotonic fluid. You need to give isotonic fluid. We will see about that. And which can lead to the cerebral edema or brain demyelination. It is very nicely written in the table in nephrology. So you can read it from there. Even in emergency medicine, it's nicely written in one table. So you can read it from there. Then comes the what are you going to do is basically provide the fluid and then electrolytes maintenance by the daily requirement. How you are going to, either you can remember this one and either you can remember this one. Both are applied, okay? But the only difference between them is this is 24-hour and this is hourly rate. Don't forget this one. I saw a couple of people who just remember this formula and don't know if it's for 24-hour or it's for hourly. So you need to know this formula is applied for 24-hour, like a whole day. And this one is for hourly. That's why it is being compatible. So what happened is 1 to 10 kg, you need to give, either you can remember this one, either you can remember this one. You are going to give 100 and this is for 4. In the next 11 to 20, how you are going to put 50? Because the first 110 will be applied along with this 50. That's why it is becoming this 1000. This 1000 is coming from this 100 multiplied by this 10. Okay, that's why this 4 and this 40 is coming from 4 multiplied by 10, because this 10 you cannot exclude just because it's 11 to 20. This 10 is also the weight of that particular person, but now you have to add 11 to 20 as well. So just don't make up this is 4 2 1, so I have to remember 4 2 1. 4 is going to add into the next 2, and then 2 is going to add into the next 1, and then along with it. Okay, so this is the starting, then you have to add this one to this one, then this one to this one. Okay, I hope that makes little sense. So this is 100, then you can add 1000 along with 50 for every kg more than 10 kg, so every 10 kg, right? So now we are going to switch on to how you are going to, so this 1000 is going to be add to 50 because next 10, right? So 50 multiplied by 10 is equals to 500. So 1000 multiplied by 500 is becomes to 1500 along with this new 20. So you have to remember the previous ones will be adding into the new ones. So along with this one, either you can remember this one, it's easy. If you can remember this one, easy. Both are fine. Okay, then you are going to start with the IV fluids. Serum electrolytes should be measured. Then you have to, in the children's, all the maintenance should be dextrose components due to their higher risk of hypoglycemia. So might be they can present with hypoglycemia. So you have to start with the dextrose component, especially if they are NPO. If they are, say that the baby was vomiting for so long and they didn't give any food, right? So you cannot start with isotonic saline or something. Maybe you can put the patient into more hypoglycemic state. So you have to start with the dextrose, especially if they mention the patient is NPO. Okay. Then common IV fluid combination used in pediatrics is basically a normal saline, dextrose 10 or dextrose 5 in the first month of the life. So this is something which is written how you are going to give it, that this is a maintenance fluid. This is the basically, if your patient is coming, you are going to give the bolus. But dextrose only when the NPO. If it's they said they were giving food, like most of the cases they were giving food, right? So you have to start with the normal saline bolus, and then the maintenance you can give dextrose. So along with it, if you are giving too much saline, baby will jump into hypoglycemia. If he was not presenting with hypoglycemia, but you give normal saline, now he will can present with the hypoglycemia. So you are going to give dextrose 10 water. Then the first month of the life is basically dextrose 5 along with the year. So this is the presentation. If your baby is coming with a newborn, you can give dextrose 10. If first month, then you can give dextrose 5 along with 0.4 per 4-5 normal saline. So what happens is if you are giving dextrose, potassium start moving, out of the cell and then causing hypokalemia and stuff like that. So just like the DKA presentation, if you remember, so you have to add potassium chloride along with it. The children's without special consideration, so you can give these ones. Decreased risk of hyponatremia. Other options are this one. So you can see how the age difference is making the fluids difference as well. Most important thing is basically when correcting sodium abbreviation due to fluid, so you need to see this cerebral edema. If you are correcting sodium too quickly, it can cause cerebral edema. So you have to see there is a particular limit. More than that you cannot do, not more than 12 millimole. Sometimes they ask you how much you can correct it, so you need to know not more than 12 millimole. Then therefore replace fluid slowly with the close monitoring. Aim to adjust plasma sodium by no more than 12 millimole. Management depend on the etiology, severity of the symptoms and timing, like acute or chronic, how is it. Then obviously you have to continue monitor if you are giving too much fluid, if you are giving enough fluid, if you are giving enough electrolytes, or if you are giving too much electrolytes. So you need to know accurate monitoring of the daily fluid intake and ongoing losses. So if the patient, a child receiving more than 50% of the maintenance fluid through IV, so you have to see if the serum electrolytes are disturbed or not. Then avoid iatrogenic hypernatremia because ICIADH can present. So this is a very dangerous condition. So you have to see if I give too much fluid, they sometimes ask you if they give you too much fluid, so how are you going to so how are you going to counsel the patient, or what kind of disease can present. So you have to know if you are giving too much fluid, what could happen, hyponatremia or hypernatremia. If you are giving too much dextrose, what could happen is basically hyperkalemia or hypokalemia. So along with it's kind of dangerous. So you need to treat and see electrolytes, because electrolytes are very important when you are correcting the fluids. Then comes the vomiting. Vomiting is basically characteristics of emesis like projectile, bilous, and bloody. So along with the pattern of it, you can find a lot of things in the history. That's why I always say history, physical examination. You can count on the basis of history, you can take out a lot of differential diagnosis. So it will be very easy. Even in NAC and in QE1, it's important you know the history, what kind of questions is good, and you can ask. So pattern of emesis, associated symptoms. Just because it is QE1, you cannot neglect history. Okay, so you need to know what kind of questions you can ask in history. Red flags like bilous or bloody, projectile, vomit, abdominal distension, tenderness, high fever, signs of dehydration, worse when lying down. So everything is same. Post-acid, so with the coughing fits. Then physical examination. So what are you going to find out? Dehydration, signs of any clinical status, any how you find out pyloric stenosis. So all this examination, abdominal examination is important. Then you have to check neurological examination. Maybe ICP is raised. That is why causing the edema. That is causing the vomiting. Then investigation, if the child appears well, no worrisome features, so you have to do no investigations. You just have to give the patient enough fluid, counsel them about the diet and everything, right? But if he's having a lot of worrisome symptoms, then you have to start with the investigation. Now they already mentioned where are you going to start with the investigation. Not every child who present with, if the child is coming with the first vomiting and it is bilous, or it is like it is not like it is totally fine, like having first vomiting along with food, right? But if it's coming again and again, whatever he eats he vomits, so this is worrisome. If having child for the first time, if it's coming and vomiting blood, this is worrisome. This is not something normal, even if it's coming for the first time. So you have to start the investigation. But if it's something like which is he just eat it and spit it out, so it's normal, so you don't have to do an investigation. CBC, electrolytes, B1, creatinine, amylase, lipase, glucose, so everything. In sick child, ESR, venous blood gases, culture and sensitivity, and imaging. Then suggestive of this. So on the basis of the different causes, the investigations and the findings, everything would be different. So tracheoesophageal fistula, if you pass the NG tube, it will not go all the way down. So inability to advance NG tube, chest X-ray, and the upper GI series. So you have to see if there is any fistula present between the both. So it can present with the secretions soon after the birth. After birth, he start drooling, choking, so distress. So you can see this kind of presentation can present with a fistula. If you can remember the suggestive finding and diagnostic, it would be good enough for you. Because later on, fistula is going to be treated by some pediatrician or some general surgeon or somebody like that, the specialist one. At least you need to know what my boundaries are. At least you need to know what my investigations I can do. At least you need to know what what clinical presentation it would be. So on the basis of that, you can see this is the diagnosis. Then pyloric stenosis is basically projectile non-bilous emesis within 30 minutes after feeding, fatigue, dehydration palpable. So you can see an olive-like mass in the right upper quadrant. So you do all the investigation. How this is present with the hypokalemic, hypochloremic metabolic alkalosis. That was what I was talking about. Then GERD. So fussyness of the child, spits up, arcing of the back. So you don't have to, like in the child, the GERD presents different than the adults. So don't mix it up. So just because it's presenting with the vomiting, you cannot like think, oh, this is not GERD. GERD doesn't present like that way. No, in the children's, it presents different. That's why the presentation and the finding of children's and adults are quite different. So you need to know. What are you going to start? No investigation. Just start with the PPI, like acid suppression test. And if it's not treated, then go for the pH. And then sepsis, fever, lethargy, tachycardia, tachypnea, and widening pulses. So you have to do all the sepsis workup. Then inborn error, maybe having lactosemia, Niemann-Pick, Tay-Sachs. So you have to rule out all those hepatosplenomegaly, cardiomegaly, cardiomyopathy, developmental delay, neurological manifestation. All these tests are done. Then in the bilus, if it's presenting with a bilus, this is non-bilus. Non-bilus, this is a differential diagnosis. If it's coming with a bilus, it would be below duodenum. That's why it is having this bilus vomiting, like having duodenal atresia, having intestinal obstruction. So anything that is happening at that level, that's why the bilus is already mixed, but it's not going down. Now it's coming from your mouth. So that's why the problem is bilus emesis, abdominal distension, pain, bloody stool, anything. So you are going to do is X-ray, as we already discussed in the general surgery yesterday night, that abdominal X-ray should be done. Okay. Then duodenal atresia, same. You have to see the features, everything, how you are going to present. This is basically hypochloremic, hypokalemic, and metabolic alkalosis. So vomiting presents with that. So you need to know. Then Hirschsprung, so pain and failure to pass a stools, having a lot of pain and failure to pass a stool. So this is Hirschsprung. And then meconium ileus. So you need to know the difference between Hirschsprung and meconium ileus. So make sure you know that too. Necrotizing enterocolitis, premature neonate, bilus emesis, bloody stool, and abdominal distension, intolerance of the feeds, and then electrolytes, creatinines you have to do. Then starting with the abdominal X-ray to rule out if there is any mass that is present, and on the basis of that you can move on to the next if he's presenting with any electrolyte. So you need to see if any electrolyte is disturbed, because if you just neglect because you find out the problem and you didn't correct the electrolytes, it's quite fatal and the baby can die just because you ignored the electrolytes. So don't forget, in particular diseases, electrolytes are very important. Then comes the children and the adolescents. It can present with the gastroenteritis, appendicitis, intestinal non-GI infection, increased ICP. So this is basically in the children and adolescents. Then in viral gastroenteritis, all the presentation is written. You can read it from here. So very nicely written here, interception. More than what is written here, you don't need to go all those and read it from the like how the surgery is going to be done, how you are going to what surgery is supposed to be done and stuff like that. That is quite off the family medicine level, right? So you need to at least know how to make the differential diagnosis, what are the presentation, what could be the DDs, what could be the investigations. You are going to start at least initial investigation and the basic investigations, how you are going to confirm. So this is what it is important. Then coming back to treatment, if you can remember it, it's good enough, but it is something which is going to be referred to some specialist and he is going to do it, right? So we are giving an exam where we are either emergency medicine or either we are family medicine. So then coming to the appendicitis, then ultrasound and interception, you are going to do ultrasound, abdominal x-ray. So as you can see, the presentation here, we are going to do ultrasound, but here we are doing abdominal x-ray, okay? Sorry, I'm not abdominal x-ray, ultrasound, sorry. Here we are going to do abdominal x-ray, and then here is basically ultrasound. Then viral gastroenteritis, you don't need to do anything. You just need to do a whole septic workup and see if there is anything going on. Mainly it is basically clinical diagnosis, okay? Then appendicitis, you do ultrasound. Then interception, it presents with the drawing of the legs, lethargy, red currant, jelly stool. So they will present you these kind of things. It's not like they will tell you something different in the scenario. They will eventually, if they want you to write interception, they will tell you these scenarios, these words. Abdominal ultrasound and X-ray, then basically rule out other etiologies and perforation, non-GI infection, fever, localized finding depending on the cause. Culture is basically done, and the brain imaging and chest X-ray. Increased ICP is basically nocturnal awakening and progressive recurrent headache, worse with the Valsalva, focal neurological deficit and gait disturbance. Brain CT without contrast, and LP is basically done for the ICP. So ICP is basically done with the treatment of ICP is important. So you need to know the ICP treatment. Toxic ingestion is basically finding vary by the, so you need to know what at least how you are going to start the treatment of the ICP if it's coming with it. So initial, the definitive one. So treatment is important. Then comes the toxic. Toxic is basically obviously any toxidrome has been added. Then pregnancy, you're going to start with the urine beta HCG, and then cyclical vomiting. So it can diagnose the exclusion. So you have to rule out every other thing. Then it could be cyclical vomiting. Just like that, you are going to start with the rehydration, cause of the correct electrolytes and metabolic abnormalities. Then see antiemetics if needed. Because if you are going to give antiemetics in somebody who have viral infection, what will happen is basically that all that particular wastage or whatever is coming from your mouth is going to stay inside the body and it's going to cause more problems. So you need to see what important basically antiemetics where it is needed. So make sure you know where antiemetics should be started. It is not started in every scenario, okay? Not recommended when unknown etiology and anatomic abnormalities. Then GERD, the presentation of the GERD is little different in the children's than in the babies or in the children's, in the peds than the adults. So you need to know what kind of presentation. So this is basically suspect GERD. So a baby will be having, infant will be having poor body weight, irritability, sleep disturbance, respiratory. So it might present with the coughing, choking and wheezing, and pain, heartburn, dysphagia, asthma, respiratory noise. So you need to know all of this. This is basically complication. Sorry, I'm reading complication. The presentation is like having those spit ups, having a back arc, having unable to eat. So this one here. So just trying to there you go. This is the main presentation. Having fussiness after eats, spit up, arcing of the back, poor weight gain. So this is the complication. Here it is written the complications. Okay, these are the complications. So these are the complications. If they ask you that the baby is presenting with a GERD, what would be the 3 complications you want to rule out? So you need to know at least what are the 3 first complications that I want to rule out. Maybe having sleep disturbance, having respiratory issues like wheezing and stuff like that. So you cannot miss out those ones. So you need to know what are the complications, but what are the first 3 complications that if somebody is coming to me, that I want to rule out. Okay. Then comes the investigation. Mostly you start with the PPIs. You don't have to do other than that. But if you find out maybe there is any anatomy going on, then you can start with the upper GI series, then pH and biopsy. Then obviously this conservative treatment is basically infant, how you are going to counsel the parents about the food, and then you are going to start with the PPIs if it doesn't get treated, right? So you have to tell which formula is going to change to hydrolyzed protein or amino acid based formula. So you need to know which formula you are going to get. Breastfeeding infants basically sequential eliminated diet, and then conservative is same as adult. That PPIs, acid base or acid anti-acid drugs, वगैरह. Then medical is basically prenatal feeding to enhance weight gain. Then H2, PPI, everything is written here. Anti-emetic should be given, anti-suppressant. And then in the very end, you are going to do is Nissen fundoplication. Then is basically pyloric stenosis. It's written in the general and thoracic surgery. So everything is just the same as it is written here. Pyloric stenosis here. Everything is just like the same. Okay. So everything is just like the same. If you want to go and want to read more, so you can just click on this one and you can go and read over there. Then comes the diarrhea. Diarrhea is basically definition of diarrhea varies with the diet. So you know, if somebody's coming with a loose stool, you cannot just label it as diarrhea until unless they give you a normal presentation. What was the normal, and now how come is the loose is, right? If the baby is already doing 5 or 6 times and now he's presenting with 7 times, it's totally fine, right? Having one up and down is totally okay. But if he's having more than normal, if more than normal means he was having 5 times and now he's having 10 times, this is not normal, right? So you need to know according to the age, according to the diet, according to everything, how the stool is presenting. Then on the basis of that, you can label it that's diarrhea. So then on the duration, if less than 2 weeks, this is basically acute. If more than 2 weeks, this is basically chronic. Then pathology, pathophysiology, if you want to read, go for it. Otherwise, it's not that. Then comes the diarrhea is defined as an increase in the frequency and then increased consistency. Then history is basically frequency, duration, quality of diarrhea and fever, vomiting. So you need to see then physical examination, starting with history, then physical examination, and then coming to investigation. Okay, so what are the history questions? What are the physical examination? And then what are the investigations you are going to start? So you have to start with the sepsis. Maybe it can present, but in less than having less than 2 or 3 days, it is basically normal having this diarrhea. So they said give food and stuff like that. But if he's presenting more than that and having fever along with it, all those features, this is the red flags. Bloody diarrhea, fever, petechiae, purpura, swear, dehydration, weight loss. So you have to rule out if these are red flags. So you start with the investigation. Acute diarrhea, well child with a non-bloody diarrhea often require no further investigation. So it's very important you know where you are not going to do further investigation and where you are going to start the investigations right away the patient is presenting. If it's non-bloody and is coming for 1 or 2 days, what are you going to do? It might be viral, right? Here, if you go to some family physician, if you tell them that my baby is having this loose diarrhea for last 3 days or 4 days, they said just give some water, it is viral, it will go away. But if the same baby is presenting with blood in it, this is not normal. So you have to start the investigations right away. Stool for the culture and sensitivity, ova parasite, electron microscopy, blood in the urine, CBC, electrolytes, burn, creatinine, glucose, and abdominal imaging. Then coming the chronic diarrhea, you have to rule out celiac disease, Wilson disease, all of those presentation which can present along with Crohn disease. So, so you need to know all of those presentations. So on the basis of that, they will give you a little bit of hint in the scenario. So you will see it. Then red flags, it's important you know which red flags you need to see. Then history of dehydration. Then common antibiotics that can lead to Clostridium difficile infection. Which are the most common one? You need to know that clindamycin, that fluoroquinolone, penicillin. So on the basis of the ranking, which comes first, which comes second, which comes third. Okay. So now coming to the stool, what test you are going to do in the stool. So this is a full workup that is written here. Stool, urine analysis, and then CBC, differential, ESR, C-reactive protein, smear, electrolytes, total protein, albumin, keratin. So you have to see all of these. Sweat chloride for the Wilson, celiac disease, thyroid, all of this can present with the diarrhea. So you have to rule out eventually everything if it's presenting with the chronic diarrhea. Okay, then do abdominal ultrasound and specialized test for the endoscopy. If everything has been done and nothing is coming out, so you have to rule out to the endoscopy and biopsy. Then here it is basically in all the differential diagnosis which could be the cause on the basis of their time period. Everything is written very nicely here, so you can read all of this. Okay, then is basically gastroenteritis. It's just the same, that's why I'm reading it quickly. So everything is the main thing was hydration topic that we already covered. You need to know because gastroenteritis, vomiting, diarrhea, eventually you start with the hydration, not just treating with antibiotics and stuff like that. That comes later on. First hydration, then electrolytes, then moving on to if whatever is needed. Like gastroenteritis, basically diarrhea, vomiting, fever, anorexia, headache, myalgias, and cramps. And viral, most of the causes are basically bacterial and parasitic. So 2 to 4 years, symptoms usually begin in 24 to 48 hours after exposure. Physical sign is basically febrile and dehydrated. So you have to see because this is gastroenteritis, so you have to rule out any fever. Then investigation, not usually done in young children because it is gastroenteritis, maybe viral or maybe bacterial, it will eventually go away. So then moving on, if still not because its presentation is quite worrisome, so now you're going to start with an investigation. As you can see here, mostly in the first line they told you no investigation needed. So it is very very important that in children's you didn't just directly jump into that is present in coming in 2 to 3 having diarrhea, having vomiting, having this and that. You are not going to directly jump to investigations. Okay, no investigations are done until unless the patient condition is worrisome. This is very, very important. Okay. CBC, electrolytes, stools, and maybe indicating the swear cases. Swear. They keep on mentioning only in swear cases. So, very important that where you are going to start your investigation. If IV hydration required or atypical presentation, then leukocytosis, erythrocytosis. Then complication is written hypovolemia, shock, acidosis, rapid onset, overcorrection of electrolytes, and swear dehydration. Then every this viral infection is presenting, so this is very nicely written here, all of the thing. And then management is basically mostly risk factors. You need to know if that baby is coming from the daycare or having, so on those basis maybe you have to report to the public health something is going on, that might be other babies could be affected as well, so you have to report to the public health. So this is very important. If you know the risk factors where that thing is coming from, if he had traveled, if he has vaccination history, if he's immunocompromised. So because you have to see, might be the other siblings, might be other children around him could be affected. So you have to isolate the baby, you have to see all of this presentation, and on the basis of that the treatment will be started. Because if you don't notify a public health condition which was supposed to be reported, your scenario or your answer is not sufficient. See, prevention and treatment both is required. Then early refeeding with the age appropriate diet, then odenteron should be started. Like in mild and moderate, not started. Like in very severe, you can do it. Then antibiotic, and then notify public health authorities if appropriate. Then regular uh, promote regular hand washing, because hygiene, if you start from the prevention, right, so the hand washing, we refuse it going to school, so all of this is basically prevention. Then rotavirus vaccination in the start of 2 or 6 months. Then toddlers, that is basically it comes in the chronic diarrhea during infancy, like 6 to 36 months, diagnosis of exclusion in the thriving child, and 4 to 6 six, sorry, bowel movements per day. Then the diet history, stool may contain undigested food particles and scoriated diaper rash. So it can present with a toddler's diarrhea. Then what you are going to do with toddler's diarrhea? Nothing. Reassurance, right? So here they already mentioned you don't have to give anything. No investigation. If no investigation is mentioned, you don't have to give any investigation, right? So all fours are should be, if they said how are you going to treat the patient, this fours should be written. What are you going to start with? Reassurance, fiber, fluid, fat, and fruit juices. Then lactose is same as we have already know, though investigation is needed in this as well. Okay, so I guess that would be enough for today. I will stop it.